Thank you, Chairman, for kind introduction. I'm Sik Kim from Korea. And I want to thank to the organizing committee for selecting our papers for the presentation. I have nothing to disclose. In hepatocellular carcinoma, gross bile duct invasion is rare, and the overall prognosis is known to be poor. But adequate diagnosis followed by timely and aggressive management can provide long-term survival in selected cases. However, the long-term treatment outcomes and prognostic factors are still poorly understood, and especially the optimal treatment method has not been established, such as, for example, is hemihepatectomy mandatory, or is the extrahepatic bile duct resection mandatory, or is it enough with the tumor thrombectomy? So the objective of this study was to identify optimal surgical method and the risk factors for long-term survival in patients with a HCC accompanied by microscopic bile duct tumor thrombus. So this was a retrospective study from multicenters in Korea and Japan, and the patients with a bile duct tumor thrombus involving the first order hepatic duct or more distal portion on preoperative imaging study or intraoperative findings were included. In other words, B3 or B4 bile duct tumor thrombus according to the definition by Liver Cancer Study Group of Japan. And for the staging system, AJCC 7th edition was used. So as a result, total 257 cases were enrolled from 32 institutions from 2 countries. And the total number of liver resection for HCC from each participating institutions during the enrollment period was 25,938 cases, which makes the proportion of the macroscopic bile duct tumor thrombus HCC patients as 0.99, almost 1%. And 46.7% of patients was presented with jaundice at the initial encounter. And the underlying liver disease, the most common underlying liver disease was hepatitis B virus followed by hepatitis C virus. And the patient, the total bilirubin at the admission was much higher in B4 group, and about 42% of patients underwent the biliary decompression before surgery. And by the time at the surgery, the total bilirubin was decreased to 1.1 by median number. And 62.6% of patients was diagnosed for HCC for the first time. And curative intent surgery was performed in almost 95%. And liver resection greater than hemihepatectomy was performed in 82.9%. And the bile duct, for the procedures for bile duct tumor thrombus was either bile duct resection or thrombectomy, and some patients did not have any procedure for that. And the bile duct resection was performed in 26.5% of patients. And the complications greater than Clavien-Dindo classification 2 was observed in 37.4% of patients. And 2 patients in the B4 group underwent a living donor liver transplantation with the bile duct resection together. And microvascular invasion was observed in 68.8%, and the major vascular invasion was observed in 26.8% of patients. And in B4 group, over the microscopic resection margin was involved in 22.6% of patients, and in B4 group, resection margin involvement was significantly increased when caudate lobe resection was not performed. And operative mortality was counted as 5.1%. So for survivor and recurrence analysis, the patients who underwent the non-curative surgery was excluded from the analysis. And after that, the median follow was 20.2 months, and the median survival was 45.8 months, and median time to recurrence was 12.7 months. And the overall survival rate at 1 year was 74.5%, and the 5 year was 43.6%. And the recurrence rate at 1 year was almost 50%, and at 5 year it was 74.2%. And we did some ROC curve analysis for the time differentiation, and it was a 2005, and there was a significant improvement in overall survival before and after year of 2005, but the recurrence rate was did not show significant difference. Because our cohort did not have a patient without bile duct tumor thrombus, we could not compare direct comparison with the patients who did not have bile duct tumor thrombus. So we tried to do an indirect comparison using the data from the global patient used for the AJCC 7th edition development. So looking at this Kaplan-Meier survival curves, our cohort showed the good stratification according to the AJCC stage, and the log rank test showed the significance, which is actually very similar curve pattern to the comparison group from the AJCC 7th staging system. And we also did a multivariate Cox proportional hazard regression model using the same variables used in AJCC 7th staging system, and included the type of bile duct tumor thrombus. But after multivariate analysis, the only variables that were significant were AJCC stage and the fibrosis and or cirrhosis of the underlying liver, and which was suggesting that vascular invasion is much stronger factor than bile duct invasion for prognosis. And to find out the significant clinical factors for the long-term survival and recurrence, we did Cox proportional hazard regression analysis, and these red columns are the significant factors from the multivariate analysis. There were 4 factors which were significant for both recurrence and overall survival. Resection, liver resection equal to or greater than hemihepatectomy, or performance of bile duct resection, and the micro or major vascular invasion were the factors that were significant for both recurrence and overall survival. And there were some other factors significant for both either overall survival or recurrence rate. But those were the mostly the traditional factors that were already known to the from the previous studies. So more focusing on the surgical factors, this is multivariate Cox proportional regression curves. If the liver resection was, when liver resection was equal to or greater than hemihepatectomy, the risk of overall survival, the hazard ratio decreased significantly for both recurrence and overall survival. And same with the bile duct resection, and this effect was more pronounced when we analyzed it using the P4 group only. So in summary, this collaborative study could build the largest cohort of HCC patients with the bile duct tumor thrombus, and reasonably favorable outcome can be expected in patients with the bile duct tumor thrombus after surgical resection. And clinical outcomes were mostly influenced by tumor stage and underlying liver function. The impact of bile duct tumor thrombus to survival seemed less prominent than vascular invasion. So as a conclusion, an aggressive surgical approach, including major liver resection combined with the bile duct resection to increase alveolar resection, is strongly recommended. So I want to take this opportunity to thank to all the participating institutions, and this paper recently accepted to Annals of Surgery. Thank you very much.
Congratulations, it was very nice presentation, interesting data, because in many centers the such situation with the bile duct thrombus is a contraindication for the surgery. So very nice presentation. However, I have a question, because not in all patients you observe the jaundice, but if it was jaundice, did you start with the stent or just you operate without any previous procedure?
So I think the first step is to differentiate whether the jaundice is from obstruction of bile duct or the decrease of extensive tumor thrombus or liver cirrhosis itself. And if it's think that the original jaundice is obstruction, then I think aggressive decompression is actually helping the overall outcome. Actually, the preoperative lower preoperative bilirubin is one of the favorable factors for the outcome from the analysis.
Dr. Grant, please.
And what was your technique of biliary tree decompression, and did it affect the risk of recurrence in patients with bile duct tumor thrombus?
Sorry, would you repeat?
The technique of biliary stenting, was it percutaneous transhepatic biliary drainage or endoscopic stenting? And did the technique affect the risk of recurrence in patients with, in a subgroup of patients with bile duct tumor thrombus?
About 60%, I think about 50% of patients presented with jaundice, and almost of them actually underwent the biliary decompression, and the most commonly used procedure was actually PTBD, and then followed by ENBD. And although I did not show on this slide, we compared the recurrence pattern and the survivor after recurrence, but actually the performance or non-performance of biliary drainage was not the actual real risk factor for the recurrence, but the preoperative bilirubin function was actually one of the prognostic factor, and whether to do the bile duct resection or not, or thrombectomy itself, it was not a significant factor for the recurrence or survivor after recurrence.
No question or comment? There is no question, so thank you once more.
Thank you.
And I would like to close the session. Thank you, my co-chairman.